So I just want to quickly introduce ourselves. I'm all the way to the right here. I'm Anna Chodas. I'm the Executive Director of Dementia Care Aware, and I'm a geriatrician and internist. I've been working a lot on dementia screening. I would love it if Genevieve could just come off for 1 second and say hello, and then Linda, please.
Yes, my name is Genevieve Caruncho-Simpson. By way of background, I am a clinical social worker in by training, but more recently have been really much more focused on managed care. And right now, I am a senior advisor at Family Caregiver Alliance. And I am joined by my lovely colleague, Linda.
Yes, hello everybody. My name is Linda Keenan. I'm a doctoral registered nurse, have been in healthcare for many, many years now. And over the last 20 years have been working with the vulnerable elderly population as well as in managed care clinical executive roles. And today I am assisting Family Caregiver Alliance as their clinical advisor.
Wonderful. So we have a lot of talent here in the room, and let's go to the next slide because I want to get my part over with so that we get to our esteemed experts here. One thing I want to do quickly is review what Dementia Care Aware can offer. So if you look at the D-SNP requirement, it does refer to the cognitive health assessment as a recommended tool for screening. So for our program, I just want to review that so you kind of know what the cognitive health assessment is. So Dementia Care Aware also just in general offers more education on the cognitive health assessment. So there's online modules you can take at any time. There's PDF summaries. We have a warm line so you can call and talk to us Monday through Friday or get a call back quickly if you want to talk through your clinical scenario. And then also we have in partnership with the Alzheimer's Association as well, clinical support for clinical care transformation if you're working on how do we incorporate the screening into our care. And we're always available at our email here, dca@ucsf.edu. But what is the cognitive health assessment? So the cognitive health assessment, if you dive into our materials, you'll see it's meant to be an annual screen for people 65 and older that don't have a diagnosis yet. And it really puts you on track to then follow up with additional evaluation if you need to do a diagnostic assessment. And it does so by making sure that we're screening for cognitive and functional change and getting a jump start on brain health so that we're really doing something for people, even in a screening moment, even really early on in symptoms. It's structured so that we ask a brief question. So incorporating into an annual visit, have you noticed any changes in your thinking or memory? Something like that. And we have some examples in the materials that we have in our modules. Then you apply a screening tool for cognition and function, all based on validated screening tools in the literature. So the tools that we recommend are all meant to be really brief and really applicable in diverse populations. So things like the mini cog for a cognitive assessment and an ADL IADL review for a functional screen. The other piece of this is we recommend tools that you could give to an informant or a caregiver, meaning you could actually get the full screen done on cognition and function via an informant. So if you don't have time with the patient, the caregiver or somebody that comes with them could be doing it at the same time that you're talking to the patient. So we really try to put forward tools and approaches that are incredibly practical in what we all know are incredibly busy primary care practices. So now I want to transition to our talk about D-SNPs and want to give you the overview for the CHA so that you had a sense of what we're talking about with a screen and that you know that we're here to help you sort of customize that to your practice if that's something, or your health plan, if that's something you're working on at the moment. But now we're going to get to the policy. And I'm going to start us off with a little bit of the clinical imperative before we get to the policy implications. But what we're going to go over is the current state of cognitive screening and the challenges that our patients and their families face or their caregivers. Then explain how D-SNPs, Medicare Advantage, and ACO policy changes are creating new care coordination infrastructure to address this. And then think about the dyadic approach. So how do we assess both the patient and the caregiver, which again, the cognitive health assessment does set us up to do to really improve dementia care, not just check a box on screening, which of course we need to do as well. So really briefly, why are we talking about this? And if you've come to our other Dementia Care Aware webinars, we're so passionate about this clinical imperative. And really we know we have a huge gap and we've been trying to tackle this I know we've been trying to tackle this across the state in our own settings, but then Medi-Cal in 2022 said, well, we're going to offer the cognitive health assessment and really try to encourage people to use it. So now at this point, as of September of last year, it's been reported that about 12% of people who are D-SNP members have received a cognitive health assessment or a screen. Um, in general, though, across the nation, it's maybe closer to 1 in 5 or 20%. That's often in the context of, and you may be in a practice that does annual wellness visits. But I think the bigger picture there is that sounds great and it's certainly better than nothing, but it also suggests a lot of room for improvement. And this is in the context, if we look below, of a dementia prevalence that's just increasing very rapidly underneath us. We talk a lot in dementia care aware too about the disclosure discrepancies. So many people who are surveyed will report that they are not aware that they have the diagnosis when it is in their chart. And then we also know that a lot of people who die with dementia, it looks like it was never documented. So we have gaps on both ends for identification and disclosure both. And then finally, we're learning more and more about just how higher the prevalence of dementia is in a duals population. Sometimes, kind of, when we look at coding, it's about 2 times that of a general Medicare population. But when we look at studies that really go and look at, proactively look for dementia, it's actually even higher, more in the 3 to 4 times the rate of a standard Medicare or like general Medicare population. So that always kind of blows me away that there's really that prevalence is so different. So really important to be thinking about this in the duals population. And so what we're really hoping to do is just start a process where we're detecting earlier so that we have time, patients have time, families have time to address the symptoms and plan for the future, knowing that this condition is there. So we're well aware of the incredible clinical challenges out there that dementia care, if it was ever a secure and clear pathway, is very broken. It's shattered. We know that clinically we don't have a lot of access to just quickly refer and get a dementia assessment. Screening, okay, but then what's next? So we also in dementia care aware are really working to support the next steps because we know that just screening is not enough necessarily to improve outcomes. And what we really don't want are patients in crisis, families in crisis, having known that this is error positive screened 5 years ago and never really supported with help. So the crisis here and the work to be done after we kind of get screening under our belts, but hopefully, before too long, is to ensure that patients with dementia, their caregivers, their families, really are connected. And Family Caregiver Alliance, I have to say, is a huge, huge part of that. So we know that folks are struggling in practice to get all of the screening done and then all the next steps as well. But this is a start. And so Dementia Care Aware and Family Caregiver Alliance definitely want to be a partner in that work. So I will now turn it over because I know you're all here to hear additionally a lot more about the D-SNP policy changes and how we got here.
Thank you so much, Anna. I think what Anna provided is a good clinical picture to why exactly policy is shifting. What I'm about to show you is that this 2026 calendar period represents a convergence across many Medicare pathways, and it's commonly centered around dementia care coordination. I think increasingly financially, many payers, state budgets are beginning to understand that proactive management of this condition that includes caregivers is not only the right thing to do clinically, but also financially, it enables the best chances for total cost of care opportunity for these payer groups. So, first off, I would try to reassure everyone this is a very dense slide and it will be made available to everyone as a reference slide after today's presentation. And what I want to share is a couple of key points that really prove out how many of these payment models are beginning to converge around the topic of dementia care coordination. Starting with the traditional Medicare, which is really beginning to be centered around initially through the guide model, which is an advanced payment model for dementia navigation, we are beginning to understand and codify how dyadic care navigation could be done for traditional Medicare. But moving forward, CMS is beginning to send signals through its new care model, such as the ACO lead coming in 2027, that signals where new care coordination documentation will be expected, and one of which would be related to dementia care. Um, in addition to traditional Medicare and ACOs, new incentives for dementia navigation, we're also seeing some development related to Medicare Advantage. There are new dementia stars quality measures that will be related to many plans' stars performance, and cognitive screening, accurate diagnosis, care plans, medication management, all related to dementia, will be one of the critical areas of opportunity for many providers that will be participating in Medicare Advantage. Now, take that Medicare Advantage, traditional Medicare. It is not then a surprise that, as Dr. Anna mentioned, we have such a high prevalence rate of dementia diagnosed and undiagnosed in D-SNP that there is a fuller requirement in this year's D-SNP CICM contract requirement for 2026 specific to dementia. In California, we have dyadic assessment, both patient and caregivers being now required. So beyond having a care navigator that has some dementia training, it goes beyond that. We also need to have care plans that reflect cognitive status, functional abilities, safety, caregiver needs, and more importantly, it begins to start aligning incentives to ensure that proper documentation is completed to ensure appropriate reimbursement for these key activities. So for some of us, D-SNP or dual special needs plans might be a newer insurance product. It's in essence, it's for people with both Medicare and Medi-Cal, which is really in the state of California, Medicaid. And these are special plans that coordinate both programs, Medicare and Medicaid together, which creates unique benefits for both the family, the patient, and the providers that serve them. And so in this 2026 period, what I would emphasize is that the dyadic care plan, once again, the one that integrates caregivers into dementia patients' care planning, is going to be required for 2026. That means assessing both patient and caregiver, and it's no longer part of an optional, but more of a contractual requirement for managed care plans. And with this, we create one plan that a care coordinator has to enable, towards both patient and families. And in turn, there are more complete benefits and caregiver support that is enabler for both parties. And for providers, it enables them to also simplify a couple of workflows because there's one care manager to call, and there are unique CBOs, community-based organizations that they can partner with, such as Family Caregiver Alliance and other CRCs, Caregiver Resource Centers locally, that could connect their patients and their family caregivers into other community supports. In the nutshell, we expect a pretty large demographic of individuals to be eligible for this. We see in the state of California approximately 1.7 million dual eligibles. And with the shifting pressures from state budget related to Medicaid LTSS, we see integration shifting towards Medicare over time. And so the requirement for dementia being a core element to satisfy for D-SNP will just continue to increase over the next few years. So if there's anything you would remember from my slides is that, there's new requirements coming this 2026. And so this simple checklist kind of helps remind you what we need to do for dual special needs plans, particularly those with patients or members with dementia. Number one, ask members if they have a caregiver. and make sure that if they do have a caregiver, that we assess that caregiver as part of the overall assessment process. Because what we know from science and literature is caregiver burnout is the number predictor of patient decline and early institutionalization of that patient. Number two, beyond assessment, we need to include caregivers into the care planning for our dementia members. So that is an important component of success. And so much about that care planning requires a plan that is, portable to the environment of home and community. Third piece, we need to have a dementia care specialist as part of our integrated care team. So these care managers need to have specialized training specific to dementia, and there's multiple options to how one could be trained under dementia. The fourth piece is that there are multiple community service ready to support our providers in this journey. Family Caregiver Alliance is one, and the rest of the 11 Caregiver Resource Center networks partners locally are also available to support our providers. Um, Other pieces is that coordination of Medicare and Medicaid benefits, including in-home support services, could be complicated. And so partnering with your managed care plan's care manager is important. And last but definitely not the least, timely sharing of information is going to be critical, particularly as we coordinate care at home. And so data exchange bidirectionally between these care providers will ensure timely and coordinated care is delivered to our dementia patients and their family caregivers. With that, I want to pass that over now to Linda, who will walk through the care model a bit more and why such a partnership with community providers are important. So, Linda, can you take it away?
Thank you, Jen. I'm going to be speaking to the new evolution of a care model. So we are looking at a dyad model for dementia care. And we are looking at navigating the continuum because for caregivers, this is emotionally exhausting. It is frustrating. It leads to burnout. We know it leads to caregiver mental health concerns and their health decline, all while they are trying to improve outcomes for their patient, their loved one, and ultimately their condition negatively impacts the patient with dementia they are trying to take care of. The dyad model is a composite of patient and caregiver, meaning that each complement, they impact, and it takes a dyad and an entire care team to be able to work together to achieve improved outcomes for those with dementia that are living in the community locations. So the caregiver relationship is now a dyad with the patient, and this becomes a unit of care. The dyad model assesses, intervenes, and monitors both the patient and the caregiver. This is different than a usual model of supporting the caregiver with resources, being able to assess their burnout level, their strain. This now includes the caregiver with the patient. So we are addressing the needs of the caregiver and the patient simultaneously. As a nurse, I can tell you, experience provides evidence that unless the care is culturally tailored, no matter how well-intentioned or timely, if it is not place-based, meaning eyes-on, visible, what is often told in a conversation, in a telephone call, or in a physician's office is far from the reality. We do not get a true picture of life for the caregiver or the patient. The caregiver delivers the patient care, medical adjacent, in their home. Only by visibly assessing, evaluating, and witnessing the dyad work together or not, the true needs can then be identified. Dyad engagement with appropriate consent is improved, and then therefore goals are more likely to be met. The caregiver is the community coordinator, often implementing such without being part of the true care team, without having a focus on their needs, and are unaware of who to call for what, and when to call. D-SNP in 2026 requires caregivers be included as part of the care team, provide input and feedback to the team, and also have documented problems and goals as part of an integrated dyadic care plan. So how would this work in reality? So we know that cognitive health assessment, roughly running around 12%, that percentage needs to be increased. So having that cognitive assessment in the physician's office, we then get an identification, a positive screen, and then what? So in D-SNP in 2026, a documented diagnosis of dementia is required in order to access specific benefits. So the dyad model can facilitate not just existing clients that have a cognitive decline, we can secure those patients with a cognitive decline and complete a CHA and provide dyadic care coordination for those referred, for those that have a new diagnosis, an existing diagnosis, or one that we presume will result in a diagnosis of dementia. So after a referral, we are then become the community partner. We are the community partner that then comprehensively assesses the dyad. We look at psychosocial concerns, needs, safety, and clinical areas in the new model that require attention for both caregiver and the patient. Skill sets that range from those of a registered nurse, master social worker, to a care navigator or a community health worker are assigned with the dyad's needs and the skill set needed to meet that risk level. And then we can facilitate internal escalation to a higher level of licensure to support needs that are ongoing, both short or long term, that need to have support and intervention. So this unique dyad care model facilitates timely interventions. We are place-based. We create the care plan. We improve outcomes. And most of all, in this care continuum, we are able to be transparent in the care delivery, sharing care plans, attending visits with the patient and caregiver. And therefore, that transparency is able to improve efficiency and clinical outcomes across the continuum for those that are residing in the community. So in this slide, we have Maria and Isabella. And Maria has been to her annual wellness visit. Daughter Isabella accompanies her as the caregiver. And Maria, as you can see, is with Isabella, who looks exhausted. Maria, the patient, is in a dual special needs plan. And before this dyad model, there would be an impairment documented, not necessarily a cognitive health assessment, but an impairment that may be noted by a neighbor, maybe by the caregiver herself, Isabella. There would be some resources. There may be a call, there may be an online portal, a search of social media in order to be able to try and establish what is happening with Maria, the patient. However, there becomes an overwhelming endeavor without any true improvement. And thereafter, Maria is admitted to the hospital following a fall. Normally, there would be a follow-up call post-discharge. There would be a medication reconciliation. There would be a discharge plan that most oftentimes would not involve the daughter Isabella as the caregiver, or really understand what is happening in the home when Maria gets discharged. For 6-month outcomes, we would have normally a med rec done at discharge. However, in 2026-27, CMS has removed this STAR measure from health plans for med rec post-discharge. And while it may seem that this would be an adverse decision, it actually has traditionally always scored high. And it is scored high because it was usually a checkbox, what we call a checkbox endeavor post-discharge. It was asking if medications were retrieved post-discharge, if they were going to be the same medications that were being taken in the hospital, and were they retrieved and in the home. However, in reality, such did not reflect what the DIAD model investigates to decrease admissions. Actual compliance through visibility in the home. Where are the medications stored? When are they actually being taken? Are they expired? Are refills being actually refilled and obtained that can provide evidence of adherence and financial capacity to access and sustain the ability to continue those medications so necessarily needed? So what can you do now? Well, in addition to screening at annual wellness visits, looking at care transitions, we are your partner in care. We are the referral entity that will provide a one-stop point of contact for the caregiver and the patient with dementia. We are able to then escalate internally and be able to provide those wraparound services that are compliant with the new D-SNP regulations as it relates to the dyadic care plan, the cognitive decline assessment, being able to screen both the caregiver and identify their needs and resolutions as part of their own care plan as well as that of the patient. So being the partner in care, we are closing the gap between the four walls side of care as usual. The continuum dominantly contains four walls, meaning we have acute inpatient, we have rehab, ambulatory, and then even the clinic and the office setting. But then we go to the community, and in the community, unless you lay eyes on, you are visible, you have a dyad model, and you are able to identify what is truly occurring in the home and the community with place-based staff members who are culturally tailored to this population, and the location, the geography of where they are able to secure their necessary resources, all can be for naught. So in summary, we are looking at having the dementia specialists, the dyad assessment through a dynamic care team with escalation, and then being the liaison to the providers who are so much taking care of these patients with so little time and not having the whole picture at their fingertips as they desire. So in doing that, we're creating an environment for safe aging in place and an improved and informed supportive caregiver experience. And now I will hand it back to Genevieve.
So in summary, we covered quite a bit of information today. And so what I would leave you is that the important information that Medicare is moving towards outcomes. If you're someone into policy, like me, I've been monitoring a lot of the developments coming from CMS and DHCS over the past few weeks. And simply put, I don't think anyone would disagree that outcomes-based performance is going to be the new frontier of many of our reimbursement models in the next few years. And dementia is going to be a priority condition across all pathways, whether it's traditional Medicare, Medicare Advantage, dual special needs plans, or other types of value-based care models. the 2027 performance measurement year is really beginning to focus on a tightening set of incentives around functional status and polypharmacy risk, but also making sure that in all of these models, there is an increasing requirement that these managed care plans and providers develop appropriate community-based partnerships that make these care models work. Because for the case of dementia patients, the number one ability for us to be effective is through ongoing caregiver support and education. Lastly, but not the least, practices that build these workflows now. One that is linked with complete, accurate, and linked documentation related back to that patient's dementia um, need and service requirements, positions providers particularly to better perform under 2027 Medicare Advantage quality measures, star ratings, and in the future risk adjustment evaluations. So with that, I think that it concludes our formal presentation, and I'll pause there to open it up for questions.
Yeah, thank you so much. This is definitely, I think we did an amazing job of really being efficient, but also hitting some pretty complex aspects of all this. So we really do have a amazingly large audience, so that sometimes that can be hard to manage, but I have not seen any questions yet. So I would love for anybody out there, somebody did ask if this is available later, and it is. We posted on our YouTube and connect. It's on our website as well. You'll be able to find a link to this webinar. But would love to know like why you came to the webinar, what you were hoping to learn, and please go ahead and put questions. Q&A, or looks like the chat is working for folks too. In the meantime, I'll ask one question that I think sometimes as more of a frontline person, I do get lost in the policy. Yeah, so there's a great question that just popped up about what do we do for folks who don't have a caregiver? So that also came to my mind. The other question I have though is, so someone gets a CHA, and I'll just mention a cognitive health assessment which guides you through cognition function caregiver assessment, can also be done outside of an annual wellness visit if you're not set up for that. Like my clinic is not set up for that. But you do that and you identify like a positive screen. Is that a point at which, under the D-SNP requirements, you do this full caregiver dyadic care model, or do you have to get to the point of like they have a, you've done the rest of the diagnostic workup and you're actually comfortable saying, okay, they have dementia?
So, Dr. Chodas, the first part is, with a documented diagnosis of dementia, then comes in the ability and the requirement to work and delve deeper into the situation between a potential caregiver, identifying a caregiver if there is not one, what to do if there isn't one at all, which I'll get to in a moment. And then also being able to understand that with that documentation comes a requirement to move further along the continuum by being able to provide resources to assist further, be able to open up networks, be able to then intervene in behavioral conditions, solicit the help of potentially a neurologist or a social worker for CBT, etc. So the documentation of a dementia diagnosis is key. And as you said initially, a CHA is a start, right? After that, there then needs to be a further evaluation as necessary to look at a trajectory of decline, a trajectory along a care journey of what it might look like. So while someone may be still deemed competent, but have a diagnosis of dementia, and this is what we see, this is a great time to have that crucial conversation with family, caregiver, and patient about the next steps on their journey. I hope that answers your piece.
Yeah, so I'm gonna be like really I benefit from repetition. So it sounds like you have to do the screening. That's a D-SNP requirement. Okay. And then if you're following up on the positive screen and you get to a dementia diagnosis, which by the way, dementia care work can help with that process as well. Like if people don't really know how to set up the next steps or diagnosis in primary care. But we get to a diagnosis, then you have to also ensure that the caregiver has this like real dyadic care, like they're getting assessed, they're getting
Yes.
connected to, got it. Okay. Very helpful. And to connect that, I know you're about to talk about folks who maybe don't have anybody. So that was our first question. How do we address isolated patients? But also somebody asked the care manager services that you're talking about here, is that part of the D-SNP health plan? Like how would you
Hmm. Linda, do you want to take the
access it?
first one and I'll take the second one?
Yes. So the first one, as it relates to not having a caregiver, we do know that there are folks out there struggling on their own. And so we would still provide the dyad model. However, if there is no caregiver, we would then look at possibilities for who might become a caregiver. However, we have it in the dyad model built in that if there is no caregiver, the shift in skill set, the hours to take care of the patient and assess and intervene are then done at the level of this care model. So in essence, there are some scenarios where the actual interventions, such as medication management, the ability to provide in-home services, would then come from this model either through referral or actually being there and conducting that themselves, because this model has a range of skill sets and licensure within it. So if there is no caregiver, other than a few elements of care, we would be able to take that on as if we were a caregiver, decrease caseload, and allocate additional hours to that particular patient.
As way of background, dual special needs plans are a bit of a complicated product. You're navigating networks across Medicare, Advantage, and Medicaid. And what we find is that that integration could create access issues, but also challenges in terms of care coordinations. So, whenever a member, a patient, has a dual special needs plan, every managed care plan is contractually required under their contract with the state called the SMAC agreement, where it's a state mandated contract that each of these managed care plans are contractually required. And under that agreement, they are contractually required to provide care managers in D-SNP that could provide many of these services that we are mentioned. But increasingly over time, there will be audits performed by CMS related to this model of care. So, in a nutshell, from a staffing basis, it's always helpful to contact that dementia patient's D-SNP care manager within that health plan to coordinate across that insurance products care needs. There is usually a designated individual there, but also over time, what you will find is there is an expanding network of providers beyond the insurance company's care manager that could also provide support. And community supports and other home and community-based providers like FCA stand ready to provide some assistance as well. Linda, on a practical basis, did I miss anything that you want to also call out?
No, that's correct. And
Okay, I'm gonna consolidate some of the questions in the chat, and I think this is basically gonna summarize what you were just talking about, Jen, but maybe like simplify a little bit. So I'm a provider or I have a clinic, I have a bunch of folks, some are in some D-SNP plans, it might be different plans. How would I know where I can get the care manager? Do I call the plan or, and I know you guys are, Family Caregiver Alliance among probably other regional organizations across the state as well, might be partnering. But would it looks like for a lot of folks, they could go to Family Caregiver Alliance first, or would they, call the plan and get an understanding there?
What I would tell you is that there's many avenues to navigate towards coordination with health plans. For many providers, those who are independent just you attending today's conference already gives you a leg up in terms of this evolving compliance requirement. Because fundamentally, over time, you will see much more Medicare Advantage and dual special needs plans contracts beginning to incentivize and in the future potentially create penalties for non-compliance. Because, one thing I would say for those who might not be aware for the reimbursement perspective, when you're having a dual special needs plan patient, remember, you're serving the most complex and highest acuity membership base, which connotates have higher level of reimbursement, but a higher level of risk. And many of your insurance contracts have natural incentives and support systems that will try to ensure your collective success. So step number one is be aware of these requirements. Step number two is make sure you understand which contracts that you may have natural incentives, because fundamentally we acknowledge that it's a tough time right now in the provider world. The good thing about this is there's a lot of new quality related measures that create natural incentives for many providers' success. But also, there are new support partnerships that will try to ensure your collective success as well.
What you're talking about also touches on something that keeps coming up in the chat, which is how are people being audited? And like, where should people be recording this? I know for the CHA, there's a requirement or a cognitive screen, basically, like it should be in the provider notes somewhere. Somebody else could do it as long as it said that the provider reviewed it and interpreted it in some way, like positive, negative. I talked to the patient about it. But yeah, do you have a sense of how clinics, health systems will be audited? And then that relates to a similar question about like, when is all this rolling out if you can just review it again? So like, how are people being audited and how many plans? I mean, I think it's now, right? Is what if I'm not mistaken, it's 2026.
Yeah,
so it's
yeah.
now. Okay.
Maybe Linda, given she's closer in terms of this work operationally, because fundamentally, well, I don't want to oversell the compliance risk, because fundamentally what we're talking about this is evidence-based practice. This is including caregivers in dementia care planning, assessment, ongoing support is best practice and the best way that we can serve our patients, but also financially provides additional new incentives in the future for those who may have quality incentives in Medicare Advantage and D-SNP. But Linda, on a practical matter, do you mind speaking to this? Because you're more aware about the audit process, but also how we drop certain compliance, assessment through our documentation.
Yes, certainly. So with a dual special needs plan, you are looking at Medicare regulations as well as Medi-Cal in California regulations. And therefore, you have two sets of regulations to contend with. As a nurse, I can tell you, lo and behold, wherever you have best practice, quality follows. And so therefore, you have the capability here with Medi-Cal and Medicare together in this dual program. At a health plan, you are going to be having documentation in whatever documentation system or electronic health record you have. You would document that there is an awareness based on a cognitive health assessment you probably would have retrieved as a case manager from a primary care physician's office to start with. And then you would document any outreach assessments that you would normally do. The difference is now, and I mean now, January 1, 2026, if a patient has a documented diagnosis of dementia, there will need to be active contact, integrated care plan goals for their caregiver, even at the health plan, not just the patient. This also requires a ICT yearly, which has been a dual regulation for some time in many states. But also at the health plan level, you are looking for D-SNP members to actually now have a visit that are face-to-face, other than an ICT, which is usually telephonic. And then a dementia specialist, specific training assigned to the care team. Someone who is familiar with this population and this diagnosis. And this is all a challenge because oftentimes electronic health records do not do an integrated care plan or for sharing at this time. There is also the ability and the need in a managed care organization for auditing to have all of this in a place where both federal and state audit takes place. And so the documentation needs to be concise, it needs to be timely, it needs to be available to be shared amongst providers, and there needs to be a different level of consent. Now you're including a caregiver. So a lot of these elements are new to a D-SNP in a part of a managed care plan. In a community setting, we have looked at these and have be able to resolve these concerns and be able to look at the caregiver in entirety. And this makes a difference from an auditing standpoint, because while this does and is enforceable as of January 1, 2026, we know it may well be a little bit of a slow roll from a federal and state perspective, but nonetheless, we are really looking at outcomes here. So we're not just looking at checking a box to say this is what we have done. We are looking at engagement of patient and caregiver. We are looking at a face-to-face assessment and knowledge of the caregiver, what the caregiver does, where does the caregiver live, could be in another state. So we are looking at place-based assessment here and true understanding of a caregiver that is often hard for a care manager at a care plan, especially when you're doing a transition of care from a hospital setting. Most oftentimes that caregiver is not right there at the bedside when everybody wants to discuss the case. So it can be very difficult, but it is right now live that with documented diagnosis, this is what occurs.
This is so helpful. I think, again, a message I'm hearing is just, it's pretty new. So like, it's not like, major auditor pressure is going to come down, but there's this responsibility now of plans and providers to be working on this. That's maybe a little vague and certainly not policy language, but I wanted to point out a couple other questions, and thank you, Jen, for answering some of these because the questions are really, really good. Where essentially is the responsibility? I think this just, again, connects to the auditing question about connecting with the care manager. And before we answer that, I'll just say we've talked about the dementia care specialist training, and somebody from Centene contributed that they have done the training, they have trained folks, they're doing screenings. So I think sometimes the health plans are able to do screenings for, of people in the community. And so, yeah, if you have any other thoughts about like where you feel like the responsibility really should lie for the connection to the care manager. And yeah, I'll pause there. And then we'll pretty quick here, we'll show information about the CE and information about our website so that you guys, if you want, can sign up for the next webinar, which will be about the dementia care specialist training. Oh, right on cue. Who's referring to the care manager?
Yes, so there are various ways. We're talking about a care manager that can be at a health plan, or we're talking about a care manager that could be at Family Caregiver Alliance. Ultimately, it is the managed care plan who is contracted to provide the dual program for seniors that is ultimately responsible for everything that is in their contract to include these new regulations. Oftentimes, they delegate to a community resource, to a community business organization, and they work together, care manager of the health plan and care manager in the community at, say, Family Caregiver Alliance. And so what we're looking at here is that there is not always the capability when we're looking at a face-to-face, that is a face-to-face for a care manager or a care coordinator to actually do a face-to-face in the home, place-based. We know you've got, thousands of members in duals in managed care plans, and the capability to go into people's homes on an ongoing basis can be very cumbersome and difficult, especially in extremely large areas of populace. So there can be a referral from a primary care physician to the D-SNP managed care plan. And then there can be an arrangement where that managed care plan has already decided they are going to delegate these services in the home for dementia patients, especially with caregivers, and all that incorporates. And to do that, then they would refer the case to the community business organization. And then we would take it from there within the dyad model. And then eventually, if that contract exists, then specialist primary care physicians can actually refer directly to the Family Caregiver Alliance for that patient who is already under that agreement with the managed care plan's care manager, and they work together. It is a whole team effort. There is a lot in the community that a health plan care manager is not necessarily able to wrap their arms around. And so it is it's a true family affair, so to speak. And so there's several ways for referral, but they're the two main ones.
Thank you. Thank you. Yeah, a lot to absorb. I hope people do have time and find like the recording helpful. Again, we want to be there for any questions that come up. Yeah, thank you so much. And here's Jen's email and our email at dca@ucsf.edu. Also, please suggest additional topics on this that you feel like would be helpful. We would love to serve everybody in that way. And I think the respite benefit you just mentioned, that was a specific question somebody had. And it looks like the care managers, if somebody has the dementia diagnosis, would be expected to coordinate some of the respite. We've said our emails multiple times, but just want to reiterate, we're here for you to continue to field questions. Very grateful for the rich conversation and questions. I'm glad we had so much time. And a tremendous, huge, enormous thank you to you, Jen and Linda, for your quick and really accessible summary of what is so complicated and new, but we all feel is so important. And we're all here to hopefully help folks who attended today to meet these requirements and help their patients. So we always like to end on time if we can. And we do really have a bunch of resources for you guys. This is stuff also about how to work with caregivers in healthcare. Our program called Caregivers as Partners in Care Teams. Dementia Care Aware was a kind of a home for a lot of this. Clarity is legal, meeting older adults and caregivers' legal and financial needs for planning for the future. Not actual financial planning, but legal financial planning. And then, as many of you know, we've partnered across many webinars with the Alzheimer's Association, which is statewide and nationwide, to bring information and healthcare transformation information as well. If anybody wants to do a dementia program and get age-friendly healthcare recognition with the IHI, we're doing a learning community and helping people to do this. So we'd love to help set you up with a CHA program, a pathway, or whatever works for you guys. Or maybe you're focused on this aspect, which is connecting to CBOs, connecting to the Caregiver Alliance and other organizations to get people the care manager services they need. So please, you can register for the community there, the action community, or feel free to reach out to us separately. And once again, we've done it. Minor miracle. We are going to end on time. And thank you so much. Thank you so much. This is always an amazing moment to learn from you guys. So really appreciate it, Jen and Linda. Have a wonderful afternoon, everybody.